advisor with Superior Health, and this is week 6 and the final day of our series for infection preventionists. And today joining me is Patty Leonard, Jessica Henkel, and Amy Magner. And we're going to kick it off today by first letting you know just a couple things. One, Patty and I are together today. We're sitting literally on the same side of the table. So if we take and turn our heads and look at each other inadvertently, it is bad habit, but when we're not used to having our coworkers right next to us as we present on these webinars. So it's a little different, but we're getting ready to host an in-person infection preventionist day here in Michigan tomorrow. So we're very excited about that. But also we are sitting in the business center of a hotel. So we hope that we will try to limit the background noise. Hopefully it won't get super noisy here. So go ahead and let Patty kick us off as we start today. Patty, if you want to bring the slides up. Okay, we're going to go ahead and get started. So
today we're going to talk about doing some infection control rate calculations. So you can look at your percentages each month to see where you're at with your infections, and talk about some wrapping up things like your end of the month reports and how to look at them, as well as some tips for survey readiness. And hopefully we'll have time that you can share your best practices as well. So Jess, we have a quiz we're going to start with. So it's a long-term care facilities. Urinary tract infection rates have increased by 5% over the prior month. Which of the following best practices would help reduce additional urinary tract infections? So it looks like for the majority would suggest getting a team together and perform a root cause analysis and then develop a plan to address that. And I would agree with that. Not that staff education on hand hygiene might not be appropriate as well. So being as a lot of your facilities are using electronic systems right now for your calculations and your reporting, this is probably already done for you. But do you know how the systems are calculating your infection rates? Jess has a couple of resource links that she's going to drop into chat for you as well. But in general, your infection rates are reported by infections per 1,000 resident days. So, and your resident days per month are the number of residents that are in bed at midnight for the month. So if you have a census of 30 and there's 30 residents in your building every day, and there's 30 days in the month, your resident days for that month would be 900. So if you had 5 urinary tract infections, you're going to divide 5 by 900, and that's going to give you 0.00556, and then you're going to multiply that by 1,000, and that will give you 5.56 urinary tract infections per 1,000 resident days. There are different ways to calculate this. Sometimes numbers are multiplied by 100. I would say make sure that you're consistent with how you're reporting this out each month. So that way you're able to compare things. But in general, the standard is reporting infections per 1,000 resident days. And as well as sometimes you're going to report urinary tract infections per numbers of Foley's, or wound infections per number of pressure injuries, or pneumonias for those residents that have feeding tubes. Report out things that are meaningful to your facility. So then what do you do with this data? At the end of the month, you've got all these numbers and, rates per 1,000 days or percents. What do you do with them? You need to compare them to the previous months. Is there a change? And that's where as the poll spoke, if there's a change, you need to investigate, do the root cause analysis, get a team together. You can't just take it at face value and say, oh, we had an increase this month, kind of shrug and move on. It requires investigation, and then you need to make a plan. This is part of your QAPI. If it's big enough, you might even need to do a performance improvement project. Look at what you can look at your CASPER reports if you're looking at some of your different UTI rates, for example. What are the state rates? What are other facility rates? Where are your range? Are you in the lower percentile, the higher percentile? There's many different ways to look at this data, but bottom line is you need to look at it. What's the story? What is it telling you? And then based off of what it's telling you, you need to put some action steps into place to improve the numbers. And if it's an improvement, celebrate that and continue with whatever best practices that you've put into place to be successful. But you need to look at the numbers and then do an analysis, talk about this, which is actually a good place to, we had some comments last meeting about infection a committee where you'd look at your infection practices. So an infection prevention and control committee. And my guess is that you already have one of these committees. It's all your leaders from your department heads. And you do talk about these things. You talk about them in your weekly meetings. You talk about them in your daily meetings. And it would just require that you pass around a sheet and have an attendance of who's at your meetings. And then that way, especially if you're only doing QAPI every quarter, you have an infection control meeting every month. And this is where you can look at this data, bring it to that team, and you can analyze what those numbers are telling you. So the previous calculations were for outcome surveillance, and this is for process surveillance. So remember, those are the audits, the observations that you're doing of the staff completing different procedures. So it's hand hygiene, it's your PPE, it's your compliance with injection safety, it's wound care, pericare, all those things that you're checking on to make sure that staff is following your procedures and best practices. It's simple math here. If you do 50 audits this month, 45 were correct, you have a compliance rate of 90%. But again, the same action steps would apply. If you're seeing a variance, you need to investigate it. I like reporting these things and sharing them with staff. And I love graphs. You know, if you want to, you have a competition, you know, put that very, very visually out there. If you want to do an audit and a contest for resident compliance for hand hygiene, put it in a graph, make it very big, make it very visible, get their buy-in on your plan. And then at the end of the month, most likely your software might put it together for you. You probably have an Excel spreadsheet or something. I would recommend some kind of template to make sure that you cover everything each month, but you need to include the results of your surveillance. What were the results of your process surveillance and your outcome surveillance? So your process, again, would be all those different audits that you did and showing the information in a graph, for example, or in a table. But also include your analysis and your next steps. So your conclusions, what did the data tell you? This graphic here just includes some additional information that as an infection preventionist, I included in my monthly infection control report. When you're looking at your outbreaks, for example, you know, and analyze if there was resident to resident spread, resident to staff, staff to resident, staff to staff. That's your analysis of your outbreaks. I also included if I had a flu clinic, all those other things that you do each month, which are related to your infection control practices. You got new air purifiers, you did some education with your staff, you did family education, and even the bad things. Your dishwasher broke, you had to go to paper supplies, for example. So just those things that show that you have an active infection prevention and control program going on. Take credit for all those things you do. And then this monthly infection control report needs to be shared with all the pertinent people. Obviously, your medical director needs to know what's going on. And this would be good to, you know, combine that monthly infection control committee meeting when he can be there making rounds. It doesn't have to be long, it doesn't have to be fancy, but get his input on it. And then in a lot of organizations, these reports do go to the board of directors, it goes to all your corporate people, and then share all this information at your QAPI meeting. And I'm a big believer in sharing with staff. I believe in transparency. Obviously, if you're working on a performance improvement project, you need their buy-in. You need their input. How are you going to, you know, be successful? You might miss the mark on your root cause if you're not getting to the right staff to give their input. This slide just kind of goes through some things that as a DON/IP I did every day to stay up to date. We use point-click care, so I would generally try and be there to check in with the night shift staff, what was going on, check communications, and then I made rounds. I did some audits, did some education, gave the mother look to a few people that weren't wearing their masks the right way, checked isolation cards, went to our meeting and we discussed issues, checked labs, checked on antibiotics, and then added all that information to my line listing report. Made sure that I had enough and plenty of signs and symptoms down there, looked for patterns and trends, reviewed admissions. Then, during COVID especially, we had a lot of changes to the regulations and the guidance. Made sure that I was kept up to date with all those changes. And then weekly, I reviewed the vaccinations and made sure that documentation was up to date. I did the NHSN reporting. A lot of places you have weekly reporting to your corporate. I personally checked TB test compliance because we had identified that as an issue, made sure that they were all getting read. And then I did any other reporting that I had to do. And I really, truly tried to stay up to date. And that's a recommendation I would make, try and get your things done early in the morning if you can, as much because you don't know what the day is going to bring. And then monthly, keep your policies and procedures up to date if that's one of your responsibilities. I planned staff education. I tried to look at, what the results of the monthly surveillance, what did it tell me? Did I need to plan any education? If our root cause on the urinary tract infection, we felt that there was a problem with period care, I planned a period care in service or tried to set up a competency. If it had to do with not enough hand hygiene dispensers, I addressed that. Met with other departments to see if they had infection control issues and got their audits and reviewed them. I planned vaccine clinics, as well as reviewed, make sure that all the documentation was in place for that, as well as I set aside time on my calendar to complete my monthly infection control report. And I guess in general, some tips that I have, this isn't just years along to complete, but you do need to have teamwork. You need to have support of your leadership. It does require that you can delegate, prioritize, and multitask. And we do recommend that you have a backup person in case, you're entitled to time off, as well as the last one here, a biggie. Don't keep only your records on your desktop. If your computer crashes, everything is gone. And we've seen a lot of citations for facilities that didn't have any records for several months if somebody leaves. And partly it was because the records were gone, they were missing, they were unable to locate them. I would be interested though, if any of you have any other suggestions you could put into chat for how you stay up to date and how you get all your work done, because I know it's a huge lift for everybody.
We have that pharmacy is a huge help with vaccination status.
Yeah. Pharmacy is a great partner. As and their nurse consultants are great resources for you as well. And if you don't have a good relationship with them, I would make a point of talking to your pharmacist, your nurse consultant. Sometimes they do, med card audits. They'll do education for you. That's a great suggestion. Just to summarize on surveillance, it's one of the most important things that you have to do. And then as we talked earlier, it's done concurrently and retrospectively. It tells the story. So make sure that you do that deep dive. I have a coworker who talks about, slicing and dicing the data, make it tell the story for you. It will guide your work. And then a few survey tips for readiness here. We already talked about staying up to date as much as possible, making summaries of your outbreaks, keeping your line listing especially up to date, and getting all those signs and symptoms. I had really good luck with having an infection control binder ready to go for survey. Make sure that you tab it by month and you have your surveillance and all your action plans in there. Obviously, mock surveys are great, and a lot of corporations do that, but you can also do your own using the infection prevention and control immunization critical element pathway from the state. If you have somebody else that can come in and do an objective visit, do your rounds, do your audits, give feedback to staff, invest in them so that they're prepared when the surveyors, pretend to be that surveyor and interview them, ask them, say, I'm going to watch you do period care, and truly observe them. Are they following all your procedures? Do they know what to do and when to perform hand hygiene, for example. Is the hand hygiene available for them? And then chart reviews, care plan reviews are always good information to review to be ready for surveys. The entrance conference worksheet requires that you have your program standards, policies, and procedures available for them, surveillance plan, your antibiotic stewardship program, and then, as we said last week, your flu and immunization policies and procedures. They're going to ask for that upon entrance on a survey. Just a little bit more about quality measures. We talked before that they do look at your vaccination ones. They also look at hospital admissions from your facility, ER visits. So that's, going back to those quality measures that are going to measure your effectiveness of how well you can manage your residents in your facility. And that speaks to, keeping your UTI rates down, your pneumonia rates down, recognizing and addressing sepsis in your building. And this is probably one of Jana's biggies. It's minimum data set diagnosis management, making sure that when the infections are resolved, that they're removed off your face sheets, they're removed off your diagnosis lists. We've talked to facilities about their rates of sepsis, and they were admitted with sepsis and the diagnosis stayed out there for a year, and it carried on, and it affected their sepsis numbers. They were artificially inflated. They did not have that many cases of sepsis, but we got referrals from CMS to talk to some facilities and about their numbers. So, just again, monitoring your trends and addressing the issues that you see and putting correction plans in place. This is just another slide on the vaccine quality measures. So, any questions for me? Otherwise, I'm going to pass this off to Jana. And I thank you. It's been a pleasure talking with you these last few weeks.
Thanks, Patty. I'm going to turn my camera back on. And see, please note that the MDS coding instructions for sepsis have changed. Please review with your MDS coordinators. That is correct. Thanks for putting that in the note, Jess. So I'm going to talk a little bit about what does an infection preventionist do? Probably by now, in week 6, you're feeling like you do a lot of everything for everybody. And that's probably the best way to look at it. I like to think of infection preventionist as the gatekeeper for all things that keep us healthy in the facility. And really, because germs and viruses are what cause us, and bacteria, they cause us to become ill. So for your job description, I would just encourage all of you to look at your job description and make sure that the specific tasks identified that you're performing by the facility fit the threshold and the criteria of what needs to be done as an infection preventionist. In a lot of small buildings, it is not uncommon, or smallish buildings, it's not uncommon to see the director of nursing, a unit manager, an assistant director of nursing wearing the hat of infection preventionist. We often see the IP role also shared with the educator, which is probably a good combination, because if you're doing infection control competencies and education with the staff, that combination works really well. There is an F tag specific to infection preventionist. It is F882. And the fine print of your role and the expectations of the regulation are delineated in F882. And I would encourage you to search F882 or F tag 882 federal regulation. On Google, you can look it up. Find the regulation and read it. You can find it in the SOM, the State Operation Manual, and then along with all the surveyor guidance to how they would inquire about you or whoever is performing that role, and making sure that the person performing the role has the education necessary to perform the role. They have the background necessary to perform the role, and that the person that is performing as the infection preventionist in the building, a big takeaway is that they have to be in the building. They can't be located remotely. They can't be a regional individual that comes in once a week. It needs to be somebody that works for a specified time period in your building. So that also needs to be in your policies and processes. It needs to be called out as to how and what the roles are of the infection preventionist. Next slide, please. All right, this brings us up to quiz number 2, Jessica. So I'm It's a quick trick question because we haven't talked about water management yet, but I just want to hear from you all. Water management programs are part of F880. Who should be part of your water management meeting? And let's see, we've got one of two. Oh, it looks like it's a trick question because we haven't really talked about water management, but I think, we're going to talk next about water management, and I will share with you, go ahead, we can end this, Jess, and just tell me if you want to pull up share results. The correct answer is the person responsible for performing water tests, schematic of the building water supplies, and other water duties, the IP, the nursing home administrator, and any additional QAPI members, including department heads, and at least one non-leadership representative. And that comes to me, that comes to you right from the expectations and the surveyor guidance for water management. So next slide, please. So when we talk about water management, and before we talk about roles and responsibilities, I do want to share with you that part of your role as the infection preventionist is you're the captain of the ship of all things infection control. And it's a weird spot if you're a middle manager because you're not the director of nursing often, you're not the administrator. You may be a department of one. You may not have anybody that you supervise, but yet you are to be the expert of all things infection control regulations and expectations. You are the leader of the facility infection prevention program, and you're a contributing member of the water management program, but it doesn't mean it's your responsibility. And that's why we did the little talk about water management. Often when we talk to infection preventionists and we talk to buildings and we ask about water management of the infection preventionist, they'll say, oh, that's the maintenance guy, or that's the maintenance person. Well, really, as the infection preventionist, you are a contributing member and the leader of that water management program. Of course, I'm going to start coughing right now. Haven't coughed all day, so here we go. But as a contributing member of the water management program, it's important and it's imperative actually that as the infection preventionist, you understand the ins and outs of water safety and water management and waterborne illnesses and how they are transmitted in your setting, in congregate care settings, and the impact that they can have on the well-being of your residents. And not only that, but how to identify potential waterborne illness in your building. For example, Pontiac fever, which is the precursor to Legionella, and unexplained pneumonias, for example. Those should be things that trigger you to think about water safety and looking at your water management plan. So that's the little caveat and kind of sidebar, but we have had Legionella cases in all 3 states in nursing homes. So it is out there. It is becoming more and more prevalent, and we are seeing facilities tagged on a lack of a water management program under F880. And when they're tagged, what we're finding is that they haven't had they have been a meeting of one, meaning the maintenance person is the only person that talks about water management. There hasn't been a robust interdisciplinary discussion, and that the water management program has not met the criteria laid out by CMS and the expectations for preventing waterborne illness. So knowing that, you are a contributing member of QAPI. So when I mean contributing member of QAPI, you should be bringing QA data, as Patty identified, your surveillance data to QAPI. You should have water management meeting minutes. You should be talking about water testing, what you're doing from like a water run, like are we checking the temperatures? Those should be part of QAPI. And you should be providing input to the other departments. Perhaps you're asking them, again, doing that teamwork, to perform audits and surveillance for you or for their department, and bringing that data back to that QAPI meeting. And then obviously you're the educator of infection control content and program expectations. And I'm going to guess that you're looked at as the subject matter expert on all things infection control. And quite honestly, because you do so much surveillance and auditing, you're kind of the SME for surveillance and auditing. And as a former administrator, my infection preventionist was probably who I utilized the most to help train new department managers on how to do this thing called auditing and what QAPI was about. Because you're doing it, infection preventionists do it so routinely that it's part of their job, and they really are great at being able to explain that. So next slide. All right, so F882, again, just going back to the fine print of the role of an infection preventionist, it does pull from all the F tags from F880 to F945. Please pay attention to the certification and education requirements. And if it's a shared role in your building, please make sure that the responsibilities are delineated out so that none of the responsibilities identified under F882 are missed by any one particular person. All right, so now we're going to talk about the related F tags, the intersection of F838 and F880. And this is talking about the infection prevention report to QAPI and the results of audits. When we talk about reporting out to QAPI, we need to remember that we have to include outbreak reviews, management strategies, adjustments to policies and procedures, and then being able to speak to how you solve the problems of your outbreak. I had a facility reach out to me this week that talked about, wanted to just talk about going from contact tracing to outbreak. What's the, help me walk through, like, it's been so while, we've been working through COVID and we've been doing this contact tracing thing. Well, now I am in 5+ residents positive and contact tracing is no longer valid, right? So they have that conversation. And as an infection preventionist, you are the person that can talk about what you did. You need to be able to tell your story and tell it confidently about your response to outbreaks, your response to new illnesses, so that, you can share just kind of that timeline of how your response went and why you did things the way that you did it. So the other thing that you may report to QAPI is any concerning events and procedural breakdowns, like contaminated food or survey findings, for example. So 838 is the facility assessment tag. And when we talk about the facility assessment has gone through some major changes this year, along with the staffing recommendations. But I want to clarify that there is a difference between the facility assessment risk assessment, meaning that emergency preparedness risk assessment that we do, and an infection control risk assessment. So as an infection preventionist, I would encourage you to read F838 and learn about the facility assessment and learn about what an environmental risk assessment is. And then go back to the CDC, and I believe we have that on our website, and we can share that with you in a few moments, on the ICAR, the infection control program assessment, and what an infection control risk assessment is. An infection control risk assessment is something that should be done with a group from your interdisciplinary team. It should not be done by one person, but it really looks at your facility's risks for specific illnesses, viruses, or other things that could potentially harm your residents. For example, waterborne illness, measles. I think I like to use the measles cases that happened a year ago. We were seeing some crop up of measles cases across the country. And if your infection control risk assessment states, oh, we have a very low likelihood of having measles, and all of a sudden your county, your city, your zip code has 5 or 6 measles cases identified, and you get that notice from your emergency notification system here in Michigan, it's called MyHIN, notifying you that there's a measles, there's multiple measles cases. You might want to bring your infection control risk assessment out and talk about it as a team. Like, okay, so we were low, we didn't identify, that we would have high risk for measles, but guess what? Our staff are of a certain age, they're younger, they have these things at home called children. and children sometimes are unvaccinated, and children can be high risk spreaders of measles. And while measles might not be an issue for your residents, because your residents by and large probably were either vaccinated or born, I think it was before 1960, you nurses, you can correct me, but I think that's when the measles vaccines came out. So people born before that are generally considered immune to measles, but your staff might not be. And if you have a high risk for measles in your building, you might want to think about what are your approaches going to be. So just a good example of what that risk assessment is. It should be a a document that you talk about and you pull it out and you look at it and remember thinking about it as something weird, some anomaly, like measles happens in your community. And then recognize how the assessment is used by the facility. And it is just that, it's an assessment of like, okay, so now we're at moderate risk for measles. What would you do differently? Would you perhaps talk to your staff about, the spread of measles? Would you educate staff on how, what type of precautions to use or what to do to clean your home if you have measles in the house and how to notify us of these symptoms that could potentially be measles? So it just kind of walks you through the steps that you need to take. Next slide. So here's just a little bit more, the difference between, and then wrapping it all up, just because we love all of those, abbreviations. The ICAR is the Infection Control Assessment and Response. It is a tool that is supposed to be conducted annually. And it's an assessment that and it's right in the FTAG. It says this in the fine print of F880, that you must conduct and document a facility-wide assessment to determine what resources are necessary to care for your residents competently, both day-to-day, during day-to-day operations and those emergencies, such as outbreaks. So I'd encourage you, if you've not completed an ICAR, if you've been in your building for over a year and you've never heard about an ICAR, I'd encourage you to go to the CDC website, search for ICAR. It is a fillable form. It is lengthy, but you can do this, get it completed. And I would complete that again as with people more than just one person. Get the input of your director of nursing, your administrator, your facilities, dietary. Environmental services plays a huge part in answering some of the questions and performing that assessment. So I think it's important that you pull that ICAR out and that you use it. And then as the ICAR is completed, there may be answers that you're like, oh, I don't think we do that. Well, I would highlight that and put that in something that maybe you want to do a performance improvement plan around this ICAR and start to look at those things that you're not so sure about to make sure that A, you've completed it, or B, that you have the steps in place to get it completed. And that assessment must be reviewed and updated whenever there is, or the facility plans for any change that would require a significant or a substantial modification of the assessment. So it's not a one and done. It's not a one time in the lifetime of the facility. It is an ongoing assessment of your infection control program's effectiveness and what it needs to be to meet the needs of your residents, staff, and visitors. So the other thing that we talked about, facility assessment, totally different document. But what do you do as the infection preventionist? Well, on the facility assessment, it does talk about infection data. It wants to know what the infection rates of your community are, of your community, your zip code, your county, your state, and how that could potentially impact your residents. Surveillance outcomes, and then the resources that you might need to respond to something like a flood, a hurricane, a tornado, a pandemic, infection outbreaks due to, or lack of supplies. Like, I don't know if any of your residents are impacted by it, but we're experiencing a pretty big hemodialysis shortage, I believe, of supplies. I think it's the fluid solutions that we're having some shortages across the country because of the hurricane impacting North Carolina, where they're built or developed. And so those are risk assessments. Like, how do you respond to those things? How do you respond to logistical changes in supplies? Remember back early in the pandemic when we were actually wearing cloth masks that somebody's loving Aunt or Grandma made because we couldn't get the supplies that we needed. So that would be part of your all hazards, your risk assessment, and your response to a pandemic, for example, in your facility assessment. So your impact, your input would be responding to those areas and aspects and talking about, okay, to get us from point A to point B safely, here's what we would need and why we would need it. Just a good example. So, all right. Any questions? That was a lot of information about a lot of unusual FTAGs that you may have never heard of, and maybe some new information for some of you. So I'm going to just take a pause before we jump into some of the fun stuff. I know it's fun for me because I like the data, but any questions, Jessica, that anybody has dropped in the chat, or questions that people have?
I haven't seen any questions come through chat, but feel free to chat them in or raise your hand and we can unmute you.
Yeah, I'm gonna stop sharing. I have Patty stop sharing. All right, Patty. I am going to take us out to, so part of what we do here at Superior Health is we have a website. Yep, I'm good. So our website has a lot of things on it and just recently went through this huge revamp. If you've been out to our website in the past couple of months, you're like, whoa, this is totally different. So I'm going to give you just a quick tutorial of how to navigate our website. And here's our new website. So this is the Superior Health Quality Alliance. It is found at SH. You can look up Superior Health Quality Alliance, just look it in, type it in, and then it walks you through who we are and who we help. You might be surprised if you're a nursing home to know that we work with hospitals, clinics, healthcare agencies, and a variety of health settings. And basically, we touch any organization, including communities, that provide services to Medicare recipients. So it's not just nursing facilities, but those of us on this team primarily work with nursing facilities. So on our website, you will find a bunch of links. There's our frontline forces. This is if you don't have electronic education or you need some additional education, these are electronic media modules that you can assign to your staff. You can go in and they include post-test. And they are modules that were created by Superior Health staff. So a good resource, and there's a variety of topics that we have. There's a contact us button, but up here at the top, I'm going to take you to the resource page because I think this is where, hey, I need an audit. I need this weird audit and I need it like right now, right? We've never had that happen. Of course you have. So you've got a 2567 sitting in front of you. You got an F tag on hand hygiene, for example, under F880, and you're looking for a hand hygiene audit. How would you find that on our resource page? So you go to the resource link, go to the resource library, and you can come down here and search. See that I did searches already. We'll do hand hygiene audit. And come over and search hand hygiene audit and hit enter. And it will bring you up to a variety of all the different types of hand hygiene audits that you could possibly want that we have we've created or we've borrowed or we've grabbed from other websites and shared because we like to utilize the best tools that we can find out there for nursing facilities and make it super easy for you to find resources that you need quickly. So this saves you from having to create those tools yourself, look for them online, come to our website, grab the resources that you need. And in the event that you're unable to locate it, you can go to care setting and you can pull up long-term care. You can pull it up by topic, all those topics. And then you can also just do the search, put in what it is that you're looking for. And I think, that to me, that is the best way to come in and find information. And even if you just have one word and you do like, for example, PPE, it will bring up resources that have PPE in them somewhere. So again, keyword, full sentence, 2 or 3 keywords, you can find your resources. But great information. The other thing that is on our website is the events tab. And I know most of you found that because you probably either heard about this event through one of our weekly updates or by coming onto our website and clicking on the events tab. You can click on the events tab and it will take you to any of the upcoming events that we have coming up. So here we are. Here's this today. This is us. And this is what Patty and I are in Birch Run here today for tomorrow. And you can see that we have things ongoing all the time. So just encourage you to come out and do look at this and just check out the website periodically to see if there's anything new. But again, if you're needing something immediate, a resource, go to that resource library, and it's the easiest way to get to that item. So then the next item I'm going to take you to is the data website. So I don't know if many of you know, but one way that I, as an administrator, when I was working in nursing facilities as a regional or as an administrator, I like to see the trending of what was being cited by state surveyors in my area. And there was really no really good way to do that. And then they created this website, and this is a quality certification and oversight report. This is the CMS data on surveys of all healthcare entities that receive Medicare as a funding source. And this is the website link. I don't know, Jessica, if you can copy and paste that or put that into the chat. We can grab that. It's just HTTPS and it's QCore. If you search QCore CMS, it should bring you to this website. Free site, open to the public, open to anybody. So once you're in the site, it will ask you to agree to not do anything nefarious with your data, which, okay, you're going to say yes. And then you'll get to this page. And on this side, you can look up all of these different care entities and see their survey data and see what CMS has been reporting or reported out on through their state survey or the licensing agencies. So we're going to go down to nursing homes. And this is that site I told you I have to say yes to. So we'll go to nursing homes. And under nursing homes, I can get all of these different reports by based on, your citations, average number of deficiencies. Citation frequency is one that we utilize quite a bit because we'd like to look at citation frequency across the 3 states to see trending. And what we look for is citation frequency by state, and then look at citation frequencies with high level cite tags, meaning G's or higher. And we use that data then to go in and review 2567s at your state websites to kind of look at the trends around the different topic areas to see what's trending. And between that and what we get reported to us from you all on what you're experiencing in your 2567s, we use that data to create education like this and we hope to hit the high topics, the topics of importance based on our findings and what you're telling us. So let's not pick on our region. Let's go to a different region and we'll pick on, usually I pick on Atlanta because I can pick on Atlanta. So we'll go down and we'll pick on Atlanta. And let's do, let's just run the report for citation frequency by the CMS region out of Atlanta, Georgia. And this is going to be a big data set, so it will take a while to run. Did I pick it correctly? Okay. Then of course, it's probably not going to work today because, it's not working. Look what the deal is. Different internet probably, and Patty just said it's probably different internet. Sometimes internets give me a run for my money when I'm out and about, but normally it works. Oh, there we go, just a little slow. So this is the criteria. So you can slice and dice the data as how often you want to do it. You can do a lot of different things. You can do year. It goes back to I think 2017, 2016. This data it goes back quite a ways. And you can see that in Alabama, F880 has had 17 citations. And this is all F tags. So it still remains the #1 cited F tag. And then if you click on it, you can see all the nursing facilities in Alabama in fiscal year 2024 that were cited for infection control. And I would encourage you to think about this website and use it to kind of track and trend your own region and area to see what your state survey teams are looking at. As we know, state survey teams kind of go in themes and they start to look for trends. They're just like us, they look for trends. And if they go into 2 buildings within, 3 months of each other and they've cited F880 on a specific topic, I can guarantee you that those same surveyors are going to look for that topic or that area of concern in the next 3 or 4 surveys that they go into. We see this as patterns when we work with facilities on directed plans of correction. For example, last year we had an interesting trend of facilities getting tagged for, I believe it was PPE, failure to use PPE during COVID outbreaks at pretty high level. So we immediately responded to that by putting out some education for facilities. Good information, just want to share that with you so that you have it, so that if you're not familiar with this website or this area or this data, that you can go to it and utilize it to look at citation frequencies, trending, and then just look at the data across your region or area. The other area that we utilize and then we go to are your state-specific licensing websites and look at the data that your states put out, including the 2567s and plans of correction that facilities have submitted. Just really see what, what gaps there are, and from a tag perspective, like what are we seeing? And then how can we help with education and resource support? So I think that's it. Are there any questions that anybody has or anything that anybody would like us to cover? Okay, well, go ahead. We're gonna let Patty share again so she can share the last slide.
While they're looking for the slides, I did drop in the chat a post-event evaluation, so you can let us know what you thought of the training. And then just to make sure our training was effective, we have a post-training knowledge check. It's just a few brief questions for you to answer to let us know if our training was effective. If you would do that before you log off, that would be great.
There we go. End of the slideshow. Technical difficulties over here, ladies and gentlemen. I know. This is what happens when you have lots of us on the go. So thank you again for joining us. And please, if you have any questions, please reach out to all of us, one of us, any of us. Any resource needs, we can help you and assist you for at least the next couple of weeks. And we look forward to helping and supporting. And if you're coming to join us tomorrow, or I think Minnesota has their event in 2 weeks, we look forward to seeing you then. Thank you all. Take care. Bye-bye.